Welcome to Time to Talk Science and Medicine. This podcast is brought to you by the Translational Institute of Medicine at Queen's University, Kingston, Ontario. My name's Dr. Charlie Highmarch, and I'm an assistant professor and researcher at Queen's.
And my name is Stephen Archer, and I'm a cardiologist and researcher and also the director of the Translational Institute of Medicine, or as we affectionately call it, TIME.
In this series, we are fortunate to talk science and medicine with some of the most accomplished translational researchers from Queen's University and beyond. We want to know what their dangerous idea is, an idea that a concept they're working on that, if true, would change the direction of research as we know it. But we also want to find out a little bit about the person behind the discoveries. In previous podcasts, we sat down with clinical and basic scientists from both Queen's Universities and beyond to discuss a diverse range of research, including cancer research, cardiovascular disease, bleeding disorders, and animal care.
So today we are very fortunate to have Dr. Tony Bai with us, who's an infectious disease doctor and also a researcher in the area of understanding a very nasty bacteria called Staphylococcus aureus. Tony, thank you very much for coming on the podcast. Before we get too deep into your research and clinical practice, though, I'd like to ask you about your origin story.
Great. Thanks for having me. In terms of my origin story, I was born in Tianjin, which is a big city right next to Beijing in China. And I came to Canada when I was 10 years old with my parents who immigrated here. And I grew up in Toronto, Ontario. And the reason I went into medicine is because my mother was a cardiologist back in China. So when I was little, I remember being in the hospitals and playing with the stethoscopes and seeing my mother seeing patients at the bedside. And then when she came to Canada, she had to switch her careers because it's so hard to get a license here. So she went into clinical research. So then she brought me along whenever she does some research for poster presentations and conferences, which has been really fun for me. And then when I was in undergrad, my mom introduced me to a statistician, Dr. Tomlinson in Toronto, who was looking for someone volunteer to do some of the stats analysis for various research projects. So I took on that position. And then one of the research projects that I was helping with is with Dr. Andrew Morris, who was an infectious disease doctor in Toronto. So that's how I got introduced to my mentor, Dr. Morris, who has been very kind and took me on and guided me towards a career in infectious disease. Always wanted to be in medicine because I saw how my mom helped other patients to get better. But Dr. Morris made a convincing argument that for infectious disease, we get to cure people of their disease. And it's very rare for doctors to say that.
That's interesting. The whole issue around volunteer people in the laboratory. I run a research lab, as you know, and I've sort of taken the position that I don't take in volunteers, mostly because I feel I don't want to be taking advantage of people and not paying them. But on the flip side, I guess your whole career started off with your being willing to be a volunteer and someone being willing to accept you. So I don't know if you reflected on that at all.
Yeah, I did. So I feel like as I got further in my career, I get to reflect on how privileged I am. But I do feel like I took on that volunteer position because of my privilege in terms of my social economic status. I mean, I was able to be in a volunteer position without any pay, and that wouldn't be a problem because I got the support of my parents, who was very supportive of my career aspirations. But I think now looking back, I feel like other people who may be less privileged, and I try to make a point that whenever I try to take on a student, I always try to find pay for them, because I feel like getting paid is always better than volunteer.
Mm-hmm. I think that's especially important in normalizing that some students actually have to still make rent, and they don't just have the privilege of just being able to kind of out of pocket, just do extra time to enhance their career.
Yeah, it's very humbling to see how much a graduate student get paid in terms of to do the graduate studies.
Yeah, it is interesting. And the flip side, though, is had you not had that volunteer activity, we may be short one infectious disease doctor and researcher. And so it is interesting, like a lot of things, it's complicated. If there is money, it's certainly better to pay people. But TIME is very committed to our graduate students. We have created several awards to try to add $1,000 or $2,000 a year to each of our graduate students in the TMed program, because I agree, if you want people to go into careers in research and medicine, you need to inspire them and show that you respect what they do. So good point.
Yeah. And I think those small amount of money means a lot to the students. So I'm sure they really appreciate it.
100%. So on this show, we kind of ask the question about people's dangerous ideas, researchers' dangerous ideas. And we broadly define that as an idea that, if was true, that would change the direction of your field. But actually, I guess what we're really asking for you is, how does your hypothesis disrupt the field of study as it currently stands?
Yeah, one of the dangerous ideas that I'm currently working on is something concerning survivorship. We think about cancer survivorship, where cancer survivors have complications or had to deal with the sequelae of cancer treatment or the disease itself. But we tend to exclude infection from those diseases we think about, because normally when we think about infection, you either die from the infection or you get cured. And once you get cured after stopping the antibiotics, we usually think that people go back to their baseline health.
That's right. It's kind of one and done, right?
Yeah. And but we're finding more and more that that's probably not the case. I mean, when I'm in clinics and seeing patients after finishing a month of antibiotics and we think they're back to their baseline health, the patients tell me that, doctor, like, I don't feel like I'm back to my normal self at all. And usually it's because their body has taken a toll from the infection. So I guess the dangerous idea I have is that currently the studies we have assume that if you get cured of infection, you go back to your baseline health. But I think there's still significant morbidity that the patients experience that we're not capturing in the current studies that we do follow up to a month or 3 months. So one of the things we're looking at is the long-term health outcomes for people who got cured of their infection, to see if there's any morbidities or sequelae.
And I think the audience might be familiar with the term long COVID. So this is the idea that beyond an initial infection, there's actually a lasting effect on health and well-being that goes well beyond the antibiotic course. Is that what you're suggesting for other infections?
Yeah, exactly. So I think COVID and long COVID is at the forefront of everyone, so everyone knows. But I think similarly, I think there's parallels to be drawn to other severe infections. Like the one that I'm working on is for Staphylococcus aureus bloodstream infections, which is a severe infection. And we do find that people do have lots of sequelae and morbidities after surviving the infection.
It's interesting. Influenza, you and I talked about this in preparation for this podcast, about the data around influenza and cardiovascular disease. Can you just remind me of that?
Yeah, of course. So one of the strongest evidence that we have in terms of this complications after infection is from pneumonias and influenzas. And there's lots of observational studies on the large scale in the United States, Canada, and elsewhere, where show that if you were hospitalized with a severe influenza, subsequently within the next months to a year, you're at a significant higher risk for cardiovascular events such as a stroke or a heart attack. And it's not just limited to influenza. Dr. Corrales Medina at the University of Ottawa has shown that for any bacterial pneumonias, there's a significant risk for heart attacks and stroke.
So it's an excellent point, because we actually have a cardiologist in-house. And of course, the obvious question is cardiology aware of this, and does it integrate that into healthcare currently?
Of course we are, Charlie, yes. No, I mean, it is interesting that I actually do in my clinic often arrange for people to get their either influenza vaccine, just encourage it, or administer it. And same with Pneumovax. Those are two vaccines which have been shown to, I mean, the cardiovascular risk reduction is actually pretty dramatic with influenza. I forget the exact number, but it is surprisingly large, and it sort of competes with statins and other conventional cardiovascular preventative measures.
Yeah, that's true. I had to look back to the numbers as well. I don't remember, but we have large trials now looking at the benefit of influenza vaccines to prevent cardiac complications such as heart failure.
Yeah.
And Dr. Mark Loeb, which is a renowned vaccine researcher, has published trials looking at the benefit of influenza for heart failures and other cardiac complications.
So just following that dangerous idea line, so recognizing that diseases, infectious diseases, may have some long-term sequelae, how would that change your practice as an infectious disease specialist?
Yeah, I think how it changes our perspective is first, I think it just means a longer follow-up and the more comprehensive management of the patient. where as specialists, we tend to focus on this one issue that we're dealing with, which is the infection. But once that's been dealt with, I think now that if we know there's other complications or declines in health, then we should arrange longer follow-ups to see these patients and try to optimize their health. For example, after people are discharged from the hospital and get cured of their pneumonia, perhaps an opportunity would be for infectious disease doctors to look at their cardiovascular health and see if there's anything that we can optimize.
I guess when you're talking to patients about the value of vaccines and considering that significant percentage of the population is vaccine hesitant, that in addition to preventing the infectious disease, which they might wager they're going to survive, it also improves their cardiovascular health and prevents renal failure and other conditions. So maybe another sort of angle to promote vaccines.
Yeah, for sure. And I think that just adds in terms of the cost savings for the vaccines that maybe we haven't accounted for yet.
Mm-hmm. Yeah. Well, I think you did a good job of explaining this in terms of that we could understand. So maybe we can have you just sort of talk about your dangerous idea now in terms of if we were high school students, although arguably if we were high school students, our brains might work better. So you may not have to change it much, but just even defining what Staphylococcus aureus is and putting this in terms that a high school student would understand.
Yeah, so I'll try my best. So my research mainly focuses on one bacteria called Staphylococcus aureus, which is a gram-positive bacteria that we have around our skin, around our nose, that everyone has. But once it gets through the skin, it can cause infection. And once it causes infection, it can spread to the blood. So this is called a blood infection or bloodstream infection. And it causes a very severe infection because our body has a severe response to it, causing sepsis, which is just our body's response to the infection with a lot of inflammation. And a lot of people die from this staph blood infection up to 10% within the first week, 20% within the first month, and 30% within the 90 days. And my research is mainly looking at how can we try to decrease this mortality. But more of my research is moving towards once that you have survived and finish your antibiotics up to the 3 month mark, what happens afterwards? Because we are seeing that people are still having lots of declines in their health, such as a decline in how their kidneys are doing, how their heart are doing after recovering from the infection. And they tend to live with these for a long time, for years.
So the name Staphylococcus aureus, obviously that's a very long Latin name. And one of the great things about Latin names is that they're so incredibly descriptive about the shape or the color. So maybe just tell our audience and tell the high school audience what Staphylococcus aureus actually means.
Yeah, so I had to look this up because they didn't teach this in medical school, but I think Staphylococcus aureus is split into 3 parts. So Staphyla, which is Greek for grapes, and then coccus, which is Greek for berries. And it's mainly because when they looked under the microscope in the late 1800s, when they found Staphylococcus, it looks like clusters of grapes. And then the aureus is Latin for gold. It's because when they grew the bacteria on the plate, they see a sort of a golden sheen on the bacterial colonies. So it's quite descriptive. So it's golden colonies and looks like clusters of grapes under the microscope.
Sounds far more beautiful than the infection that it causes then in that case.
Yeah, definitely.
So obviously you're doing, so we've heard about your dangerous idea and obviously your research hasn't stopped, it's continuing. So can you tell us about your latest discovery and how that is going to contribute towards clinical practice or our understanding and knowledge of these diseases?
Yeah, so one of the research studies that I'm working on right now is a quality improvement study on Staphylococcus aureus bloodstream infection. In the last 10 years, we have done studies to show that when you manage Staphylococcus aureus bloodstream infection, there's lots of components. For example, you need a thorough workup, you need an echocardiogram to look for infection of the heart valves, and you need to be on the best antibiotics to treat the bacteria. And we find that whenever we involve infectious disease specialists, our expertise is useful to make sure that we hit all of these quality of care indicators. And from our observational studies in Toronto, we've shown that whenever you consult or involve infectious disease in the care of patients with a Staphylococcus aureus bacteremia, they tend to do better. in terms of their quality of care, but also in terms of a lower risk of dying from the infection. So as a result, there's lots of policy changes that led to it being mandatory for infectious disease specialists to be involved in certain hospitals, such as in Toronto, in Hamilton, and in Vancouver. And I'm hoping we have implemented this just for the last year or two at Kingston General Hospital.
So this is a great example of actually research that's being done, kind of reinforming the community and actually changing clinical practice.
Yeah, it has certainly changed clinical practice. And when we study it here, when we compare it to before we implemented this policy to afterwards, there are significant changes. And one of the more profound ones is we found that we decreased the mortality rate from about 29% to 23%, which is huge.
Yeah, and that's interesting because I think it reflects the fact that there are bacteria and then there are bacteria. So Staphylococcus aureus, in addition to having a complicated name, has a track record of being quite dangerous. And I think there's something in your research that reflects, a change in practice to deal with what is it about staph that is so bad that requires a high-powered specialist like yourself to be involved rather than a simple country cardiologist like me writing a prescription?
Yeah, I think all infectious disease doctors respect Staphylococcus aureus because it's such a virulent organism. The bacteria itself has lots of tools in terms of how to evade the immune system, as well as invading the tissues and also causing spread to other body parts. For example, the bacteria itself releases lots of toxins that sort of accentuates your inflammatory response and sepsis. And most people can die from septic shock. As well, it has these enzymes that it can degrade the local tissue so that it can invade deeper. So that's why sometimes we see it goes from a skin infection to a muscle infection to a bone infection or a joint infection. And then once it gets to the blood, it can really go anywhere. And we like to think Staphylococcus aureus as this sticky bacteria because it has lots of proteins that can cause fibrins to form around it. So once it attaches to the heart valves, it can stick there. And that's why we have something called heart valve infections or endocarditis.
So I know in the UK where I'm from, though, there's periodically something comes up in the news about kind of like superbugs that are resistant to all kinds of drugs. Staphylococcus aureus also has kind of resistant strains. So how do they factor into your kind of big dangerous idea and also changing clinical practice?
Yeah, so it's a great question. So one of the main resistance patterns we see for Staphylococcus aureus is whether it's resistant or sensitive to methicillin. So when it's susceptible, we call it methicillin susceptible Staphylococcus aureus, which is MSSA, for which many penicillins and beta-lactams work well against MSSA. However, there's a large proportion of Staphylococcus aureus that's methicillin resistant, which is called MRSA, methicillin resistant Staphylococcus aureus. And for that, there's a very limited number of antibiotics we can use to treat it. The mainstay antibiotic has been an antibiotic called vancomycin, which is an old intravenous antibiotic that we use that has been pretty effective at treating MRSA. However, it's really hard to dose. It has a very narrow therapeutic range. So we tend to see lots of toxicities from it, mainly in terms of acute kidney injury. So we are participating in the SNAP trial, which is an international trial looking at different antibiotics to treat for MSSA, also for MRSA, to see which is the least toxic and the most effective.
Yeah, and it's interesting that you were mentioning that apparently vancomycin resistance is not as big a problem as one might expect. Normally, you give an antibiotic, and if you give enough of it, you breed bacteria that are resistant to that antibiotic, but not so much with vancomycin, apparently.
Yeah, I think it's one of the advantages of vancomycin and that we've been throwing vancomycin and MRSA for decades. However, there's very little resistance to vancomycin. There's only a handful of cases in the US, and there's none thus reported, as far as I'm aware, in Canada. I think the theory is that when the bacteria induces this resistance, it has to change sort of its cell wall and shape such that it's less fit as an organism to cause infections and propagate. So there's sort of a balance between balancing between fit and antibiotic resistance.
So the bacteria might be resistant to the treatment, but the requirement for the treatment is less because the impact of the bacteria is lower.
Yeah. And then I think there's sort of the bacteria has two selective pressures. One is to develop resistance so that it can live with vancomycin exposure. But the other one is if it does that, it's less able to be fit and compete with other bacteria of causing other infections or invading the tissue.
So it's interesting. Now our listeners are probably totally freaked out. You told them about this sticky, nasty bacteria that makes all these toxins and can cause septic shock where your blood pressure collapses. You wind up in an intensive care unit on antibiotics. And then you've also said that this bug lives on our skin. So we're walking around with staph and some of us in our nose and on our skin. So what is the actual risk today for if you're a healthy person of developing a staph infection? Is there something that makes you susceptible to this?
Yeah, so the way I like to think about it is there's risk factors of how to acquire this bacteria that can invade through the skin and also how our immune system deals with it. A normal, healthy person who has a normal immune system are at very low risk of getting Staph aureus bacteremia. In terms of the risk factors, we think about things that causes breaking the skin. For example, when you have a dialysis line, which means that you have a permanent line that goes through the skin into your veins, that could be a portal of entry for the bacteria. And also we see people who inject drugs where they introduce needles through their skin that can carry the Staph aureus through the needle into the blood. And also we see people who have weakened immune system. So whether they're more older or they're on a lot of immunosuppressive medications to treat for other diseases where they may be prone to a more severe infection.
Yeah, it's interesting. In my lab, Kim Dunham-Snary, who's a faculty member now, but she was a postdoctoral fellow at the time, did a fascinating study where we took green fluorescent protein labeled Staph aureus. So they look like little grapes, like you said. And then we put them on a culture plate with human neutrophils that we harvested from volunteers in our lab. And the neutrophils look like Pac-Man, that video game. And they would literally go around the slide, picking up all the bacteria, eating them up one at a time until one neutrophil, one white blood cell, one of your immune cells might have had 30 or 40 bacteria in it. And then they release this toxic bomb of oxygen radicals that basically dissolves and kills the bacteria. And I guess the message you have is that sometimes that works. Most of the time that works. But sometimes it doesn't. And sometimes those neutrophils are not very good Pac-Men.
Yeah, I think so. I think there's lots of factors that contributes in terms of the infection getting the upper hand. But most of the time, I think we should be assured that our immune system usually can take care of the staph bacteria.
If not, we'll be posting Dr. Bai's home phone number. You can call in if you're worried.
See in comments. So before we move on to the next question, I just want to raise something that we all chatted about before the podcast, and certainly it was news to me. I'm not a clinician, but I was always laboring under the misapprehension that one of the best things that we can do for kind of a bacterial infection is to finish the course of antibiotics. And of course, it made some logical sense that if you destroyed every last single one of the bacteria in the system, they'd have no chance for kind of adaptation or speciation to. That's no longer true. And actually, again, evidence has been used to actually change those standards. Can you discuss that a bit?
Yeah, of course. So I just want to be specific. I think it's still true that you should finish the antibiotic course that's been prescribed. But what's changing is that we're learning more about what's the best duration to treat infections with antibiotics. And before, when we invented penicillins and discovered these new antibiotics, these durations are very arbitrary, and that's why you see them in terms of weeks or in terms of multiples of 7s or 5s or 10s. However, now we have more and more trials, non-inferiority trials, to show that the general theme is shorter is better. And that's the theme for ID docs today, meaning that we find that shorter antibiotic duration tend to be enough to treat the infection. And we find that when you prolong the antibiotic duration, you're harming a lot of the gut bacteria, but also you're prolonging the exposure to antibiotics such that you would increase the risk of having more resistant bacteria.
So always finish the course of antibiotics, of course. But the research is actually changing the way that ID doctors prescribe drugs for these kind of
Yeah, so it's the prescribed duration that's changing, but that'll be up to the doctor. So you're okay to still finish.
Do what you're told.
Duration, yeah.
I think with the rise of interest in the microbiome, bacteria have had their reputations resuscitated, and they now are seen as not all bad, but some of them are good, and we don't want to kill the good guys along with the bad guys.
Absolutely.
For sure, yeah.
So, Dr. Bai, every scientist or physician, and you're both, has a bump in the road on their trip to success. So what have been one or more bumps in the road that you've experienced as you try to expand our knowledge of infectious diseases?
Yeah, so I think one of the challenges that I tend to experience as an early career researcher is the competition for funding. I think one of the things is infectious disease may not be the priority for a lot of the funding agencies, mainly because there's lots of funding going to cancer or cardiovascular disease, because those are the top two causes of death for Canadians. But also, I think there's just a very limited cap funding in Canada in general compared to elsewhere in the world, such as the States. And it just becomes very competitive in terms of how many of us, in terms of the early career researchers, try to secure these fundings. And it's sort of like a snowball effect where if you secure the fundings, then you get more publications, and that way that leads to more fundings. But along the way, a lot of the early career researchers and some of my colleagues are giving up because it's hard to get jump started. And it's hard to compete with a lot of the very well-established researchers who's very accomplished.
Yeah, and during the pandemic, I think Canada got a little bit of a wake-up call about the importance of infectious disease doctors and that we didn't have enough of them. And it's very interesting that although we talk a lot about family medicine and it's not a race to see who's most hard done by, when it comes to the pay scale of infectious disease doctors in Ontario, it's near the bottom. And yet, during the pandemic, we suddenly were all terrified and realized that we needed people that actually understood virology and helping us deal with SARS-CoV-2. But I think in general, do you sense that I know you're a young physician, but do you sense there's a lack of respect for infectious organisms and the impact they have on human health?
Yeah. In my opinion, infectious disease is the most important topic and career aspiration.
Dr. Gerald Evans, your boss will be delighted to hear that.
Yes. But yeah, I do feel like sometimes infectious disease is placed to second place to other of the more focused things, like we talk about, like cancer and heart disease. But I think it's just because we do such a good job for public health in terms of preventing so many infections that we tend to forget in terms of the death and morbidities caused by a lot of infections worldwide. For example, 1 in 4 people have TB worldwide, and 10 million people have the TB disease in any year. And then 1 million people, more than 1 million people, usually die from tuberculosis in 1 year. So it's still significant infectious diseases. But I think now when we have these pandemics like COVID-19, it just makes us more humble in terms of knowing that there's still lots of infections that could affect all of us. And I think it's a great motivation to say that we need to train more infectious disease doctors, and they're very valuable.
Just to follow on from that, are ID doctors as a profession contingency planning for the next time something like COVID-19 happens? Is that already something that's been discussed and thought of within your field?
Yeah, for sure. I think what COVID-19 has showed us is that that we should always be prepared for a possible new virus causing a pandemic, and I think public health and infectious disease doctors are now more cognizant and more careful in terms of monitoring for new infections and be prepared for the next time.
You can see that with Mpox following closely on the heels of COVID, even if it hasn't been quite as broad. But I think what's more disheartening is seeing the rise of polio, a disease that we'd essentially defeated through vaccination and arguably through our own human, for want of a better term, folly. have somehow managed to take our foot off the neck of polio, and it's rising again. And now there are mass vaccination programs going on to try to prevent the spread of polio, which is sort of, like, I guess, like all diseases, the best friend of infectious diseases is war and instability. But yeah, so I guess be prepared. But maybe if peace could break out on this little planet, that might
just for 10 minutes.
We might not need so many.
Then we have just disinformation to deal with. But
That's right.
That's at least one challenge rather than two.
Yeah. And I think one of the things that my experience from COVID is that I'm very grateful for the advances in terms of the medicine and technologies that we have. I mean, the mRNA vaccines was the game changer in terms of saving people's lives, and how fast in terms of how it was discovered against COVID and implemented in trials was very impressive for me. And then I think what we learned from this pandemic, we can definitely apply into the next one.
Before we wrap this podcast up, we'd like our audience to just get to know you a little bit as a person. So we have some slightly more fatuous questions, some slightly more fun questions we're going to hit you with. So the first one is, what is your favorite food or your favorite meal? And can you cook it yourself, or do you have to rely on somebody else?
Yeah, it's a good question. I think my favorite food is sushi. And I feel like it's a very good comfort food that I love. I tried to do it. I can do it, but not very well. You know, we got the rice, the special rice.
It's always the rice I get wrong.
Yeah, it's the rice, but then always the rolling thing. So I got the roller too. And then we tried it. It tastes okay, but never as good as what you buy in restaurants.
I think a general rule, Tony, is it's like haircuts, never do it yourself.
It's true. It's true.
So music, what type of music do you like?
Yeah, I feel like it depends on what I'm doing. I do play the piano, so whenever I'm working, I do find classical music to be the best. I really like Debussy. That's my favorite composer. And I think that just helps me concentrate because there's no lyrics or anything to it. And then because my wife really loves Taylor Swift and other pop music as well, so I had to endure listening to those songs in the car.
I'm a big fan of her folklore album. I will not tolerate any ill speaking about Taylor Swift.
In which case I shan't speak.
Yeah.
So outside of music and making sushi, any other hobbies? How do you spend your time when you're not being an ID doctor? Because I think the audience probably thinks of doctors being kind of, you're only ever in that role. But, what do you do when you're not thinking about being an ID doctor?
Yeah, it's a great question. So I have a 2-year-old son, William, who's taking up all of my free time right now. So there's not much time for hobbies. But I think before we had William, I think one of my hobbies was playing the piano. And I really enjoyed playing the piano, but I had to get a good piano at my place first.
Well, I'm maybe on the other side of my family, so I can probably say, you'll get some free time back in probably 17, 18 years' time, possibly. I don't know if any extension of that.
Yeah, that's true. But I do understand you have a hobby with William. You've been practicing for Halloween. Are you allowed to spill the beans what William is going as this year?
Yeah, we have a dinosaur costume for him. Where we'll go trick-or-treating with him dressed being dinosaur. I think it's a pretty safe one for 2-year-old boys. Of course, there's lots of photos right before going to trick-or-treating.
Yeah. Child in dinosaur outfit. I mean, you absolutely can't beat that.
It's perfect.
That's the justification for parenthood. I think, Charlie, you have the last.
So I'll take the last question. And the last question was, if you were a cartoon character, which cartoon character would you be and why?
Yeah. I'm so glad that I got the chance to prep for that because I'm not sure if I could answer.
I'm laughing because we always put people on the spot and people go, oh, I don't know. And then presumably afterwards say, oh, I should have said that. So
yeah. So thank you for giving me the time to think about it. It's the most important question of the interview. But I thought more about it and I grew up watching SpongeBob SquarePants.
Brilliant.
And then I think I would identify myself as SpongeBob SquarePants because we have 3 similarities. So one is he's always an optimist. So I feel like whenever I do research, I always have high aspirations of what we should be able to achieve. And 2, I think he's very hardworking. He takes his job very seriously. And I feel like I'm hardworking too. And I really enjoy the job that I do. And 3rd, he's nerdy and uncool, which is what I am too. The only difference is he doesn't know it and I know it.
I don't know if we can tell Tony that SpongeBob is not a real person.
What? I'm our house, my son, especially my youngest son, Ted, big fans of SpongeBob. So I've watched a lot of it and I completely agree. It's so much fun. If only they can get that recipe for the Krabby Patties, I think everything will be okay. Okay, so thank you very much, Dr. Bai. And on behalf of myself, Dr. Archer, would like to thank you for taking time to talk to our audience today about your research and about your kind of like your clinical practice as well. Also, to our listeners, we'd like to thank you for taking the time to get to know Dr. Bai, and we hope you enjoyed the show. If you enjoyed this episode and would like to get to know more about research at Queen's University or to share this podcast, you can search for Time to Talk Science and Medicine wherever you normally look for podcasts. Thank you.